Good morning, everyone. And my topic is pre-anesthetic checkup. What is preoperative evaluation? It is nothing but it's a process of clinical assessment that precedes the delivery of anesthesia for surgery and for non-surgical procedures. It consists of the consideration of information of multiple sources that may include the patient's interview, medical records, physical examination, and findings from medical tests and evaluation. Goals. It is to ensure that patient is in the best condition. Patients with unstable symptoms should be postponed for optimization prior to elective surgery. Anesthetic drugs and techniques have profound effects on human physiology, hence focused review of all major organ systems should be done prior to surgery. The objectives are to maintain doctor-patient relationship, to obtain patient data, and to plan the anesthesia, and to get the patient consent. The steps of preoperative visit are first identify the problem, then do the risk assessment, then the preoperative preparation and the plan of anesthetic technique, which includes the clinical examinations into three phases where in phase 1 history taking, that is the gathering of information, and in the phase 2 physical examination, that is by objective findings. Phase 3 explanation is by information giving and decision making. In phase 1 of history taking, demographic details, presenting complaint, history of presenting complaint, past medical history, previous anesthetic history, like any history of difficult intubations, any history of allergy at that time, drug history, family history, social history, and systemic inquiry. Demographic details are date and time of examination, patient's name, date of birth, age, weight and address, source of referral, doctor's name, source of history, like patient, relative, and caretaker. Physical examination is by general examination, measuring the blood pressure, pulse, respiration, temperature. Clinical assessment by jaundice, pallor, cyanosis, clubbing, edema, and hydration status, measure the weight. Coming to systemic examination, cardiac examination, pulmonary examination. In the special examination, assessing the airway, peripheral venous access, and spinal examination. Coming to the airway, the incidence of difficult intubation reported to range between 0.13 to 5.9%, and it can be predicted, and expert anesthesiologist is called for the case. So, evaluation is the first step in the management of difficult intubation. It is assessed by two: Mallampati grading and laryngoscopic view by Cormack-Lehane grading. In Mallampati grading, it is divided into four grades, where in the grade 1, full view of soft palate, fauces, ovula, tonsillar pillars are visible. In grade 2, soft palate, fauces, upper portion of uvula is visible. In grade 3, soft palate, uvular base, and in grade 4, only hard palate is visible. Coming to the Cormack-Lehane grading, in the grade 1, entire glottis is visible. In grade 2, only posterior commissure. Grade 3, tip of the epiglottis, and in grade 4, no glottic structures are visible. This is the picture of Mallampati grading and also the Cormack-Lehane grading. In the Mallampati grading in the class 1, where you can see uvula, soft pillars, hard palate, and soft palate. In grade 2, soft palate, upper portion of the uvula, and fauces are visible. In grade 3, soft palate and uvular base is visible. In grade 4, only hard palate is visible. In Cormack-Lehane grading, where you can see the vocal cords and the glottic structures are seen. Here the glottis is seen and only posterior commissure is seen. In grade 3, only tip of epiglottis is visible. In grade 4, no glottic structure is visible. Airway is evaluated by measuring mentothyroid distance, which is of normal 6 centimeters, mentosternal distance normal 15 centimeters, mentohyoid distance normal 3 finger breadth, Neck movement, flexion and extension of neck, history of radiation, nasal cavities. This is the picture showing the thyromental distance, measuring the distance from the mentum to the thyroid cartilage. This is normal 6 centimeters. And this is the real image of Mallampati grading. When it is called as difficult intubation, if mouth opening is less than 3 centimeters, limitation of neck movement, micrognathia, microglossia, protrusion of teeth, short neck, and morbid rupicity. This is the picture showing of difficult intubation. As you can see in this picture, there is a huge multinodular goiting covering the entire neck. And this is the case for difficult intubation. And this picture showing the whole, the mandible area is covered and the oral cavity is fully covered with the carcinomatous growth. And here the whole whole mouth is covered of the carcinomatous growth. Airway examination normal. If the opens mouth normally, adults if they greater than 2 finger width or 3 centimeters, able to visualize at least a part of the uvula and tonsillar pillars with mouth wide open and tongue out, patient sitting. Normal chin length. Adult's length of chin is greater than 2 finger breadth or 3 centimeters. Normal neck flexion and extension without pain or paresthesia. In the airway examination, if it is abnormal, there would be a small or recessed chin, inability to open mouth normally, inability to visualize at least a part of uvula or tonsils with mouth open and tongue out, high arched palate, tonsillar hypertrophy. Neck has limited range of motion, low set ears, and significant obesity of the face or neck. Airway assessment predictive test sensitivity is 50 to 60% by Mallampati modified test where the visibility of pharyngeal structures, Patel test that is where the thyromental distance is less than 6.5 centimeter, where there is a mandibular protrusion that is a class C, inability of the lower incisors beyond the upper incisors. The Wilson's test, the radiological assessment of mandible and cervical spine. This is a slide showing the Wilson's risk test, where the risk factors are here the risk factors are weight, head and neck movement, jaw movement, receding mandible, and buck teeth. Weight, if the weight less than 90 kgs, score 0, score 190 to 110 kg, score 2 more than 110 kgs. Head and neck movement, score 0 above 90 degrees, score 1 about 90 degrees, score 2 below 90 degrees, jaw movement, score 0 if interincisor gap more than 5 centimeters or if subluxation more than 0. Score 1 if interincisor gap less than 5 centimeter and subluxation is 0. Score 2 interincisor gap less than 5 centimeter or subluxation less than 0. Receding mandible, score 0 normal, score 1 moderate, score 2 severe. Buck teeth, score 0 is normal, score 1 is moderate and score 2 is severe. ASA grading system where it is classified till ASA grade 6. ASA 1 is the normal healthy patient without organic, biochemical or psychiatric disease. Mortality 0.06 to 0.08%. ASA grade 2 is a mild systemic disease with no significant impact on daily activity like mild diabetes, controlled hypertension, obesity. So unlikely to have an impact 0.27 to 0.5%. ASA grade 3, severe systemic disease. It limits the activity like angina, COPD, prior myocardial infarction. Probable impact is 0.18 to 4.3%. ASF4 is an incapacitating disease. It's a constant threat to life, like CHF, unstable angina, renal failure, acute MI, respiratory failure requiring mechanical ventilation. The major impact would be 7.8 to 2.3%, 23%. In AC grade 4, sorry, AC5 is a moribund patient not expected to survive 24 hours like ruptured aneurysm, 9.4 to 51%. In AC6, it's a brain dead patient whose organs are being harvested. For emergent operations, add E after the classification. Coming to the cardiovascular examination, pulse, rate, rhythm and character and volume are assessed, blood pressure, jugular venous pressure, height and character, ankle edema, presence or absence. Inspection, look for any scar, abnormal vessels, lump, chest shape, apex beat, position. Palpation, localization technique, confirm apex beat, character, presence of thrills and peripheral pulses on both the sides. Percussion technique, precordium, size of the heart, auscultation technique, heart sounds and murmur. Symptoms of the following problems sought out in all the patients, like ischemic heart disease, hypertension, heart failure, conduction defect and arrhythmia, and peripheral vascular disease. Patients with a history of MI are at great risk of preoperative reinfarction, the incidence of which is related to the time interval between surgery and infarct. The presence of unstable angina has been associated with a high perioperative risk of MI. The presence of active congestive heart failure has been associated with an increased incidence of perioperative cardiac morbidity. So coming to the revised cardiac risk index, for the patients undergoing elective major non-cardiac procedures, high risk type of surgery, history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, preoperative treatment with insulin, preoperative serum creatinine more than 2 mg, and the rates of major complications with 0, 1, 2 or 3 of these factors are 0.5, 1.3, 4 and 9% respectively. American Heart Association Task Force on Perioperative Evaluation of Cardiac Patients undergoing non-cardiac surgery has defined 3 risk groups: major, intermediate, minor. They indicate that recent MI places the patients in the group of highest risk after the period. A prior MI places the patient in the group at an intermediate risk. The clinical predictors of increased perioperative cardiovascular risk are major. Major risk factors are with unstable coronary syndromes, recent MI with evidence of important ischemic risk by clinical symptoms or non-invasive study, unstable or severe angina, decompensated congestive heart failure, significant arrhythmias, high-grade AV block, symptomatic ventricular arrhythmia in the presence of underlying heart disease, supraventricular arrhythmias with uncontrolled ventricular rate, severe valvular disease. Intermediate risk are prior angina pectoris, prior MI by history of pathological Q wave, compensated or prior congestive heart failure, and diabetes mellitus. Minor are advanced stage abnormal ECG showing left ventricular hypertrophy, left bundle branch block, STT abnormalities, rhythm other than sinus in AF, low functional capacity, inability to climb one flight of stairs, history of stroke, uncontrolled systemic hypertension. The clinical predictors of increased perioperative cardiovascular risk are by measuring the functional capacities by metabolic equivalence of task. So one MET, one MET is by asking, can you take care of yourself, eat, dress, use a toilet, walk a block or two on a level ground 2 to 3 miles per hour. 4 METs, do light work around the house like dusting or washing the dishes, climb a flight of stairs. More than 10 METs, participate in strenuous sports like swimming, single tennis, football. The perioperative cardiac and long-term risks are elevated if the patient is unable to obtain 4 METs demand. Hypertension. If untreated and poorly controlled, hypertension may lead to exaggerated cardiovascular responses during anesthesia. So both hypertension and hypotension can be precipitated which increases the incidence of both myocardial and cerebral ischemia. Blood pressures. Optimal blood pressure is with systolic less than 120, diastolic less than 80. Normal is 130 by 85. High. It's between 130 to 139 by 185 to 89. Hypertension stage 1, 140 to 159 or 90 by 9 by 90 to 99. Stage 2, 160 to 179 by 100 to 109. According to the Joint Nation Committee 8 recommendations, if the subgroup is less than or equal to 60 years, target systolic blood pressure should be less than 150 by 1 less than 190. Less than 60 years, it should be less than 140 by 90. More than 18 years with CKD, less than 140, less than 90. More than 18 years with diabetes, less than 140, less than 90. There is a controversy regarding a trigger to delay or cancel a surgical procedure in a patient with untreated or inadequately treated hypertension. It is less clear in patients with blood pressure above 180 by 100, although no absolute evidence exists that postponing surgery will reduce risk. In the absence of end-organ changes such as renal insufficiency, left ventricular hypertrophy with strain, the benefits of optimizing BP must be weighed against the risk of delaying surgery. Aggressive treatment of blood pressure is associated with increased reduction in long-term risk, although the effect diminishes in all. But in diabetic patients, diastolic blood pressure is reduced to 90. A patient with blood pressure of more than 180 systole and 110 more than 110 diastole, they are more prone to develop perioperative MI, ventricular dysarrhythmias, and lability in blood pressure. Coronary artery disease. For those patients without overt symptoms or history, the probability of coronary artery disease varies with the type and number of atherosclerotic risk factors present. Peripheral arterial disease has been associated with coronary artery disease in multiple studies. There is a high incidence of both silent MI and myocardial ischemia in diabetes. Cardiac risk stratification for non-cardiac surgical procedures in patients with known coronary artery disease. The high cardiac risk, where the reported cardiac risk often more than 5% in emergency major operations, particularly in the elderly, aortic and major vascular procedures, peripheral vascular disease, anticipated prolonged surgical procedures associated with large fluid shifts or blood loss. Intermediate risk, if the reported cardiac risk generally less than 5%, like cardiac endarterectomy, head and neck, intraoperative and intrathoracic, orthopedic, and prostate surgeries. Low risk is with the reported cardiac risk generally less than 1%. Where the endoscopic procedures, superficial procedures, cataract surgery, and breast ambulatory procedures are done. Coronary angiography shows the evidence of adverse outcome from non-invasive test, angina unresponsive to therapy, unstable angina, especially with intermediate or high-risk surgery, equivocal non-invasive test in high clinical risk patients undergoing high-risk surgery. Pulmonary diseases, where the pulmonary complications occur more frequently than cardiac complications. Perioperative complications include aspiration, atelectasis, pneumonia, bronchitis, bronchospasm, hypoxemia, COPD, respiratory failure requiring mechanical ventilation. The top 10 risk factors predisposing to aspiration are emergency surgery, inadequate anesthesia, abdominal pathology, obesity, opioid medication, neurologic deficit, lithotomy, difficult intubation of airway, reflux, hiatal hernia. The preoperative investigations are general investigations like complete blood count and hemoglobin concentration, screening of clotting factors, liver function, ECG, echocardiogram, chest X-ray, blood sugar level, electrolytes, blood urine nitrogen, or creatinine. Preparation of anesthesia. By continuing the current medications or treatment of coexisting diseases, it is the responsibility of the anesthesiologist to instruct the patients regarding which medications to take and which to hold preoperatively, and instruct the patients to take the medications with small sips of water even if fasting. The medications to be continued on the day of surgery are antihypertensives except ACE inhibitors and ARBs. Cardiac medications like beta blockers, rituximab, antidepressants, anxiolytics, and other psychiatric medications, thyroid medications, birth control pills, eye drops, heartburn or reflex medications, narcotics, anticonvulsant, asthma medications, steroids, and statins to be continued. If the patients are using corticosteroids, then for minor surgery, the patient should take 1 to 2 times his or her usual prednisolone dosage on the morning of surgery. Following day, the patient should take his or her normal prednisolone dose. Surgeon and anesthesiologist should be aware that patient is glucocorticoid dependent and should be prepared to administer more steroids if the surgery becomes prolonged or more extensive. For moderate surgeries, and the patient should be given 2 times their usual glucocorticoid dosage orally on the morning of surgery, or 25 mg hydrocortisone IV before the operation, then 75 mg hydrocortisone IV during operation, 50 mg hydrocortisone IV after the operation. Then the dose should be rapidly tapered over 48 hours, the usual dose, if the post-op course is uncomplicated. And for major surgeries, the patient should give 2 times her usual corticoid dose orally on the morning of the surgery. Or 50 mg hydrocortisone IV before operation, then 100 mg hydrocortisone IV during the operation. After the operation, 100 mg IV QID for 24 hours should be administered, then rapidly tapered to the patient's usual glucocorticoid dose if the postoperative course is uncomplicated. And consider selectively continuing aspirin in patients where the risk of cardiac event is felt to exceed the risk of major bleeding. If the reversal of the platelet inhibition is necessary, stop aspirin at least 3 days before surgery. Do not discontinue aspirin if patients who have drug-eluting coronary stents until they have completed 12 months of dual antiplatelet therapy. Thienopyridines like clopidogrel and ticopridines, the patients having cataract surgery do not need to stop. If reversal of platelet inhibition is necessary, then clopidogrel must be stopped 7 days before surgery and ticopridine 14 days before surgery. And do not discontinue thienopyridines in patients who have drug-eluting stents before 1 year. The medications to be discontinued are like topical medications like creams and ointments, oral hypoglycemic agents on the day of surgery, diuretics on the day of surgery except thiazide, sildenafil of similar drugs discontinued 24 hours before surgery, NSAIDs discontinued 48 hours before surgery, warfarin discontinued 4 days before surgery. So the nil per oral guidelines are for solid substance 8 hours, maximum hours of fasting, formula feed 6 hours, cow's milk 6 hours, citrus juice 6 hours, breast milk 4 hours, clear liquids 2 hours. The pharmacological agents to reduce the risk of pulmonary aspiration we use are histamine 2 receptor antagonists, where they block the ability of histamine to induce secretion of gastric fluid with high hydrogen concentrations with cimetidine, ranitidine, and famotidine. And usage of antacids to neutralize the acid in gastric contents, proton pump inhibitors to suppress the gastric acid secretion by binding the proton pump of the parietal cell, gastrokinetic agents by using metoclopramide dopamine antagonist. Psychological preparation is with preoperative visit and interview with the patient and family members. The anesthesiologist should explain anticipated events and the proposed anesthetic management in an effort to reduce anxiety and diminish apprehension. Pharmacological preparation to relieve anxiety and production of sedation. Prophylaxis against allergic reactions to latex. Prevention of autonomic reflexes mediated through the vagus nerve. Prevention of nausea and vomiting. Benzodiazepines, they produce anxiolysis, amnesia, and sedation. Example, diazepam, midazolam, and lorazepam. Diphenhydramine, like these are the histamine 1 receptor antagonists, is block the peripheral effects of histamine. It has sedative, anticholinergic, and antiemetic activity. Anticholinergics like atropine, glycopyrrolate, and scopolamine, they cause antizygomatic effect, sedation, amnesia, and vagolytic effect. Antibiotic prophylaxis. Cephalosporins are the most popular antibiotics because they cover skin microbes. For intestinal surgeries, anaerobic and gram-negative coverage is needed. Antibiotics must be administered within 1 hour prior to incision except vancomycin. It should be given 24 hours prior to incision. When tourniquet is reused, antibiotic should be administered prior to its inflation. Summary of the patient preparation. The anesthesiologist who takes the time to adequately prepare the patient medically and psychologically for anesthesia and surgery will find that their job of caring for the patient intraoperative becomes easier and they're more likely to have a positive outcome as well as a satisfied patient. Thank you. And the competency number is AS 2.1 bar KH. The specific learning objectives are: at the end of the lesson, the learner should be able to describe how to assess the patient preoperatively for anesthesia and surgery and to describe about pre-medications and its importance.